I give everybody about another couple of minutes, see if anybody else jumps on, then we'll get started, okay? All right, we might as well get started. If anybody else jumps in, then they're just gonna have to catch up with us. So, before we jump in, I actually have something planned for today to go over as far as looking toward Module 8. But if you guys have any questions, anything specific, anything you ran into
Hey, Eric, I'm not able to hear you. Anybody else not able to hear?
I don't know.
I can hear fine.
I can hear, okay.
I can hear.
It's just the
Okay,
universe.
operator, just me then.
Universe is conspiring against you, Kev.
I have a question.
Please.
With the CV non-acute, so do the assessment, go through, figure out and treat, and then they come in the next time. Do you do the same assessment again?
Depends on how irritable it is.
Okay.
So the tissue differentiation doesn't really work unless the patient's having pain with movement at the time of movement, right? So,
Okay.
if we have a patient that comes in and it hurts when they turn their head to their right, or they get, dizziness or something, whatever the complaint is reproduced at the time of movement, then we can do the tissue differentiation component of that. That's the C2-3, our little washer trick, all those things. If that's not happening, then that step really is not very useful. That's not going to tell us much. So it may be a situation after you've already treated somebody the first time, they come back in and they're not having that reproduction of pain at the time of movement. So you can kind of jump back into the biomechanical exam, which I would definitely redo because you got to determine whether or not the treatment held up, right? So did you get the appropriate carryover from session 1 to session 2? The only way to tell that is to go through and look at the biomechanics of it again. So I would definitely do that. That's just going to be kind of the way. I mean, it's very similar to any type of person that walks in the door, whether it's a low back patient or an ankle patient, right, or an elbow patient. We can talk about elbows because Abby's not on here right now, right? So, yeah, you'd want to go back and look and see, is this thing still moving the way it was when they left the office the last time? But other than that, I mean, basically you have to kind of look at your own clinical judgment and decide, what other information do I need here in order to get the person better? So if they come back in and they say, say the first visit they come in and they turn their head to the right and it reproduces, a headache, right? So, or maybe some retroorbital pain, something of that nature. So you go through your process, you do your tissue differentiation, you say, okay, it looks like it's C2-3. You do your biomechanical exam and you say, all right, it looks like it's a stiff AA joint that's actually causing excessive stress there. Do your treatment, improve the range of motion as best you can. They come back in the second time and they say, I'm like 80% better. I haven't had this issue with, turning my head that much. It's, sometimes I'll wake up in the morning with it a little bit. But it's not bothering me backing my car out of the driveway, or it's not bothering me with, swinging a golf club or whatever else might be incorporated with movement of the head or neck. At that point, you probably don't have to do the tissue differentiation, but you have to see if that range of motion withheld, right? If it is holding up. So you'd probably go back and do that biomechanical exam again. That make sense?
Yep. Thank you.
Yeah, good. What else do we got?
Eric, what is TSCO? What does that stand for? I can't remember.
Trigeminal symptoms of cervical origin.
Oh, Oh, okay. Cool.
Yeah. It's,
Eric, sorry I'm joining late.
we already talked about the
I was
elbow. You don't have to
talking
worry
to
about
an
it.
adjuster about a work comp patient. So sorry.
No worries. Do you have a question?
Not right now.
No?
Let me
Okay.
get lunch.
So we should call on you first then? While you're eating. Anything else? Any other questions? Nothing you guys have seen in clinic that's made you go, not sure what that means.
Oh, I have a really good one for you, Eric.
Okay.
Just it's funny because since we've had this weekend, these people have been coming out of the woodworks for me. Like I literally just had a Bell's palsy eval just now. But that's just like classic Bell's palsy. But my interesting one was, I think it was a Monday. It was a woman who has facial pain just on both sides of her face along in like an M2 distribution of the trigeminal nerve, nothing
Okay.
on the nasal cavity, nothing around like the orbit, nothing in the jaw, nothing in the frontal or temporal lobes. Pain. She has no other complaints, no neck pain, no dizziness, no trouble, no, absolutely no complaints. And she's had it for 10 years. It's a 7 out of 10 pain. She has had like dental implants put in and removed. She's had a sinus surgery to try to help with this because the only thing that she has found that improves her pain is using a sinus strip on her nasal cavity.
Just over
And
the tape over the nose here.
yep.
Yeah.
And then using ice on her face. So I went through, I treated her like we would treat an acute trauma just because I wanted to really get an idea of like cranial nerve testing and everything.
Sure.
And cranial nerves were all clear. All her long track neurological exams were clear. Vestibular involvement was clear. Then I moved to this kind of range of motion, right?
Where you should
And
go. Yep.
absolutely nothing changed her symptoms. No cervical range of motion made it any more intense. So I'm like, oh, this is really weird.
It's a weird one.
Very weird. The first visit, I've seen her twice now. The first visit, I needled her temporalis and masseter. I didn't know. I'm going to be honest. I didn't know what to do. So I thought, well, why don't we try to go above and below and see if that influences the trigeminal nerve in any way? It did absolutely nothing for her. And then I saw her for her second visit yesterday. And again, I didn't know what to do. So I mobbed the crap out of both OAs, AAs, and her C2-3 joint. I was working on her for about 20 minutes, and she told me she's completely pain-free for the first time in 10 years.
So let me ask you this. When you were doing the range motion testing, did she have limitations in cervical motion, even if it wasn't reproducing pain?
No,
No limitations.
no. She had good range of motion. Now I did just look at it grossly. I didn't take numbers because I was doing so much the first day. But no, grossly, nothing that I could catch with my eye looked like a limitation.
Okay. So obviously what you did had some effect, right?
Right.
So the question becomes, what can cause facial pain, right? So the symptom that we usually get concerned with is paresthesias, numbness, loss of sensation, things like that. So facial pain is not something that I would look at and say, oh, this is a cardinal symptom, right? This is a red flag type of symptom. It could be tantamount to a trigeminal neuralgia, which does happen from time to time. The question becomes, is that a neurological symptom. It's
Mhm.
not, because pain's not, unless it's a lancinating pain, like a true nerve pain, it's not what you would call a red flag symptom, right? A red flag complaint. Because realistically, what our neurological signs would be is some sort of motor loss, some sort of sensory loss, or reflex loss, right? Or, spasticity and such that would come with upper motor neuron lesions. So I wouldn't look at that as a situation where I'd say, okay, we have to consider this a brainstem lesion or something of that sort of nature. So I think you did everything kind of in the right order, the way that you're looking at things. Like, well, okay, could this be a cranial nerve thing? I don't know. Let's take a look at all these things just to get a baseline. Probably a smart play. My guess is that there is some sort of cervical spine dysfunction that's just not. It's more subtle.
Mhm.
And it could be a situation where you're dealing with what you'd consider the one that I'm personally thinking of, just listening to it, is some sort of U-joint problem at 2-3, because they're a little harder to recognize right off the bat, especially if a patient. What we usually look at with side bending, because when we're looking at 2-3, we really have to look at side bending as its primary function. Usually with side bending, it occurs from the top down, right? And it occurs very sequentially. So typically if we have a lesion real high or a restriction real high, we'll get this kind of, and things will lock up very quickly. But at times we'll get a patient that will kind of lock up here, and then they'll just kind of hinge over the top of it. And so instead of getting this nice smooth curvature that occurs through this cervical spine, mid-cervical spine, we'll get this thing where things will kind of lock from here to here, and then it'll just hinge over the top of that. So it looks like the excursion's not great, or excuse me, it looks like the excursion is relatively normal. But we won't pick that stuff up until we start doing more detailed testing, like combined motion testing with quadrants, or combined motion testing with CV flexion or extension, if it happens to be occurring higher up than that. And as far as not reproducing the pain, kind of just what I was talking about with Abby is, if the pain is a cumulative sum problem, right? This is a summation effect where, it's almost the gate control theory, where it's just like, okay, we have to get to a certain threshold of stress on these tissues before the transmission of pain makes it through. That could be the issue that you're dealing with here as well, where it's just like, well, did you really stress these tissues enough to reproduce pain with movement?
Sure,
Or
sure.
does it require more repetitive movement or more sustained positioning, things of that sort of nature? The fact that it did improve with, kind of the, whatever we want to call it here, the napalm that you threw at the upper cervical spine, is a good thing, in my opinion, right? I
Yeah.
mean, it shows that you can change something,
Right.
whether it's just, normal proprioceptive input for instability, which probably needs to be tested as well, looking at the actual, CV ligamentous structure, looking at, shearing tests for C2-3 and rotary tests for 2-3 and all that sort of stuff, just to see if any of those things happen to reproduce it. But yeah, I mean, this is a good sign for me. I would go back and do the more detailed biomechanical exam for the CV region, the one we were just talking about. So combined motion testing, ligament stress
Sure.
testing, PIVMs and PAVMs there. See if you can isolate what it is that's causing issues here. And again, because rotation would tend to give you such a substantial limitation, right? If it's the OA or the AA, you'd have such a substantial limitation of rotation in one direction unilaterally. I wouldn't expect the issue to be at either the OA or the AA. My guess is you would have noticed that, even with just kind of cursory glances at motion. So my suspicion would be is you're more likely to run into a side bending issue that may or may not change with, combined movements into extension or flexion. So that's what I would look at. But the good news, whenever you see this person the next time, see if their pain is down from the 7 out of 10. See if you can isolate a little bit more specifically which segment might be involved there, and then you've got something to go on, something to play around with.
Yeah. And forgive me if this is a stupid question, but what is the connection per se to these first three cervical segments and their effect on the trigeminal nerve to create these trigeminal symptoms? Not just in my lady's case, but like, when we're talking about any trigeminal symptoms,
Sure.
why is there a correlation between trigeminal symptoms and the OA, AA, and C2-3?
Well, so in general, when we're looking at trigeminal symptoms, right, that come from the neck, basically what it is it's a facilitation. It's a segmental facilitation, but because that region of the spine doesn't have a distribution into a limb, it has distribution into the head and the face, right? So it's more a facilitation of the cranial nerves via the spinal trigeminal nuclei. So every facilitation that we deal with in the cervical spine, so say mid-cervical spine that would have reference into the shoulder girdle or into the upper extremity, or lumbar spine that would have reference into the pelvic region or into the lower extremity, those things are propagated via the connection with the substantia gelatinosa, right? And that's basically like a relay center where these abnormal sensory inputs get synapsed. And if there's too much of this abnormal feedback mechanism occurring, that substantia gelatinosa kind of ramps up the output that comes secondarily, right? So through that reflex arc, everything gets kind of ramped up. So we get these changes in motor output, meaning increased tone, sensory feedback, so increased pain with non-painful stimuli, brisker reflexes, the reflexes get ramped up a little bit. Things like orange peel skin and increased, what are we looking at? Sympathetic issues, things of that sort of nature. Everything just kind of gets wound up because the depolarization doesn't have to be as high in order to get the signal to kind of propagate through that reflex arc. The spinal trigeminal nuclei has been shown to be a continuation of that substantia gelatinosa into the brainstem. So basically, it acts in the same manner, but it does so for the nerves that affect the head and the face, which happen to be the cranial nerves. So the reference can be caused by the exact same thing, abnormal sensory feedback by any of the segments that are in spatial relation to that spinal trigeminal nuclei, right? And so that's going to be high up in the cervical spine. 2, 3, OA, and AA are going to be the most common ones that are affecting that sort of thing. Now, whether anatomically that trigeminal nuclei descends further than that, down to 3, 4 or beyond, that probably has a very individual basis, and whether or not it actually can be affected by segments below that directly, we don't really know that for certain. Texts like Gray's Anatomy, they don't specify where exactly that sort of differentiation occurs. 2, 3, I think clinically has been shown to be the furthest down that can sort of that sort of effect can occur. So that's basically the same thing. I mean, like we were talking about with facilitation, it's just that abnormal sensory input kind of bombards that spinal trigeminal nucleus, and then all of the outputs that it has can become facilitated, and that essentially looks at the cranial nerves, because then we're starting to think about what does the trigeminal nuclei do? Well, it has all of these different interconnections with various other cranial nerves, almost as like an operator center, right? Like you remember the old phone operators where they're pulling plugs and plugging them into new things and transferring calls and all this sort of stuff. It kind of functions in a similar sort of manner, in a way to kind of what do we want to say? Buffer some of the sensory feedback and how that's going to affect some of the outputs. So things like the extraocular muscles, right? They're supplied by cranial nerves 3, 4, and 6 for motor output, but the proprioceptive feedback is trigeminal, right? So we can get eye pain or extraocular pain as a result of facilitation of that musculature. from the proprioceptive feedback, not necessarily the actual motor output. Same thing with the sinuses. The sense of smell is the olfactory nerve, cranial nerve 1, but pressure reception within the sinuses is innervated by this trigeminal mechanism, right? So all these relays, we can get all these kind of funky symptoms based off of those connections from the other cranial nerves to the spinal trigeminal nucleus and that relay mechanism. Does that make sense?
Yes, thank you so much for explaining that in that kind of
Sure.
detail. That does.
No problem. Needs to be understood. I mean, because essentially, if a patient that comes in like the one you were just telling us about, and it's just, you know, you could look at it like, you know, have that weird PT face where you're just like, yeah, that doesn't sound normal, and, you know, write it off as something that you can't do anything about. Or you can look at it and say, well, it's a facial symptom. It doesn't sound like a cardinal symptom. Let's be cautious. Let's do the cranial nerve exam here. Let's go through kind of a modified acute scan here just to make sure that we're not dealing with something sinister. And then when that doesn't come up, you basically are sitting there looking at it like, well, what else could it be here? It's got, if it's going to be anything mechanical, it's got to be in those top 3 segments because it's affecting the head and the face, right? So we're not always going to necessarily understand the connections that we get as far as these oddity symptoms that we find. You know, sinus pressure and some of those sort of ringing in the ears. We may not always understand where it comes from the neurological connection standpoint. We can't write them off, right? And if we start thinking, well, this could be a trigeminal symptom, we can go through and we can do that CV exam, the CV biomechanical exam, and figure out, does this reproduce anything? Does this change anything? Do I find anything that make me suspicious that this area is problematic? You know, significant loss of motion, crepitations, clunking, etc., then there might be something we can do there. And as long as it's safe, there's no real harm in looking at it. And I usually explain that sort of thing to my patients before I go into it. I think I was telling you guys I had a patient that came in with migraines. This was last year sometime, so been a while now, but migraines in general need to be managed medically, right? There's not a whole lot that we, in theory, can do for those sort of things, but because I'd read about the potential for migraines being more of a vascular reaction to potential trigeminal facilitation. Well, if it's trigeminal facilitation, then that could be a mechanical cause. And so we can maybe potentially do something about it. Now, we didn't get this patient to not have migraines anymore, but we were able to lessen the severity and the frequency of their episodes, right? So they were having it, you know, several times a month, and we got it down to the point where they're having one every few months, every 3-4 months, something like that. And that's a huge improvement for anybody that has to deal with that sort of stuff, right? So it's just like, yeah, we would probably consider that a successful treatment, even though there's no real empirical evidence that suggests that this was definitively caused by trigeminal facilitation. But when I looked at it and we say, okay, well, yeah, you rotate really poorly to the right side, that's definitely going to be a CV area issue. We can go in and we can do some work on that and see if anything changes. And you kind of give it that, like, we'll have to see if anything improves here, but there's no risk to you. We might as well give this a run of a handful of visits and see if anything improves. You know, not a big deal when that sort of thing comes up. Most patients, especially if they're dealing with these unusual, you know, clusters of symptoms, they've probably been to the doctor, they've been to the ENT, they've seen specialists after specialists, and nothing's really changing, right? So, you know, like you were talking about with this person is, you know, they've had all these things done, and you know, the only thing that helps is if they ice their face and put on a nasal strip. And it's just like, well, what does that do? And why does that improve things? Well, ice and tension on the skin, particularly over that M2 distribution, maybe it changes some of that sensory feedback, right? Maybe maybe it's acting kind of like a wobble during when we're looking at a facilitation, you know, someplace else in the spine. It's giving that particular portion of the trigeminal nucleus, it's giving it more normal sensory feedback. And so what that should do, just like a wobble, is it should down ramp that facilitatory effect slightly. So that'd be my best guess as to why those two things were actually beneficial, or actually, the only things, quote unquote, that could actually do anything for it, is because it gave it some sort of additional feedback that the body's used to, that it should be normal for it. So hopefully that's the case, and hopefully you found something here that'll actually give either more sustained or more consistent relief.
Yeah, TBD. I'll keep you guys updated.
Yeah, keep us posted. Anything else?
Eric, can I ask a quick question about a patient?
Absolutely.
So I think it's like one of those like serial lesions that we talked about in the last class. So she kind of came in with just shoulder pain, and then as we kind of like delved into all of her symptoms, we realized she kind of had like some elbow pain, some wrist pain. Things that we kind of looked at were like upper limb tensions, which she had a ton of symptoms with median and radial. So we went into looking at like CT junction. So after we manipulate like CT junction, everything felt a little bit better, and she's been doing awesome since I've been seeing her, but she still has like some lingering pain like along her like clavicle. And I'm just like not really sure where that's coming from, but like numbness, tingling in arm is better, wrist pain better, elbows pain's better, but she also plays like badminton, so she has some pain with like during and after badminton, like along her clavicle. So I did manipulate AC joint too. I don't really know if that helped. I don't know if I maybe looked at it wrong or something, but that's kind of like her biggest complaint still. She doesn't have really any neck pain anymore. In terms of like continued limitations, she still has some limitations in, I almost feel like her like mid cervical on her left side is stiff. I don't know why.
That's
Or
the
like
opposite side of where the symptoms are.
yeah, sorry, it's all on the right side.
Gotcha.
But her left like mid cervical is kind of hypomobile, and I had a hard time connecting that to why her right clavicle still is bothering her.
There's a few things.
Okay.
So let's think about this. So mechanically speaking, if we have, I'm assuming the CT junction issue you dealt with was a facet loss of extension.
Yes. And she had like, it was stiff, like when we did like shoulder motion, that's kind of what I found is it just wasn't moving a whole lot at CT junctions, or wasn't extending a whole lot at CT junctions. So that helped with that.
Yeah, which is great. So when we deal with those sort of things, if you think about the entire cage here, the entire rib cage. So if I have a segment on, say, I guess it would be on our right side where we're kind of stuck into a lack of extension. So maybe thinking we're kind of in this position, flexed position on that right side. What's that going to do to the front of the rib cage, right? So if I flex that portion of the rib cage on the right, I'm over exaggerating that, but it's going to take that portion of the rib cage and it's actually going to drop it down right here in the front. So it's going to take the clavicle with it. Right, it's going to pull the clavicle down and forward, probably anteriorly rotate it. Now I've seen plenty of times where we'll get the opposite sort of thing, where if we get the, kind of this dumped portion of the anterior rib cage where this has come down and forward, the clavicle you would expect to kind of roll forward with it. But I've seen it where it's actually posteriorly rotated in order to kind of try and even up the shoulder girdle. So you could find either one of those things, but what that can do as far as what tissue can actually be irritable is those deep fascial connections, right? So the clavicle, if we look at it, so if you're looking at my right clavicle here from the side, basically if you have a situation where you have this fascial tissue that comes down out of the neck and it wraps around the clavicle underneath like that, and then comes downward. So the deep cervical fascia comes from above, wraps around the clavicle, and then comes downward as the clavopectoral fascia. If you have a situation where that clavicle has kind of rolled forward or dumped forward, or it's decompensated that position and it's actually rotated backward, for a badminton player that may have to do a lot of overhead motions, that may be the case. You can get pretty significant tension on that fascial tissue, right? And so that can also contribute to causes of upper limb paresthesias and plexus type symptoms, double crush type symptoms. Because all of those vascular and neurological tissues, as they exit the neck and go through that subclavicular space, they have to penetrate those fascial tissues in order to get into the arm. So tension on those fascial tissues can cause that. So when you manipulate that and you pull the thoracic spine, that CT junction, back into a more neutral position, you alleviate some of that tension on that tissue. But if the clavicle is still sitting in an awkward position as a result of it trying to decompensate that, you may have to work on sort of this anterior posterior roll of the clavicle. The best way to look for those things is to look at the two combined movements of the SC joint, which would be protraction and elevation. So protraction and elevation produces an anterior roll of the SC joint, and retraction and depression looks at a posterior roll of the SC joint. So I would test both of those two things to see if you feel an articular restriction. And then basically, if you do feel one, you're just fixating the manubrium, right? So hands.
Sorry, are they like in sitting here and you're having them
I'd be
do
in,
that?
I'd be in sideline.
Okay, and I'm moving them into those positions and feeling
Yes.
okay.
Yep, you're doing it passively, right? So you lay them on their left. If it's the right side, you lay them on the left side. I usually stand behind them to do this, and I'm just going to grasp the shoulder girdle, basically trying to get a set of fingers onto the clavicle, and I'm just going to produce protraction and then elevation, see if I feel a restriction there. If I have to compare it to the other side, I will do that. And then, test the reverse, which is retraction and depression. See if either one of those feels like it's stiff, right? Just like almost like a normal pivum pavum. And if you find one that is limited, has a limitation there, then basically all you have to do is you fix the manubrium, just put a couple of fingers on the front of it, and then you just work on moving that shoulder girdle into that quadrant, or into that combined movement pattern where the limitation is, and see if you can improve that motion. That should take a lot of tension off of those fascial tissues if you can do that. You could also go through and actually palpate just underneath or just superior to the clavicle, basically just kind of trying to get behind it slightly, in order to see if you can find any tenderness, reproduction of pain with those
she's super
fascial
tender
tissues
under her clavicle.
underneath.
Yeah.
Okay, so if it would be underneath, what that would tend to suggest is tension on the clavopectoral fascia. So if our clavicle is here and the fascia is coming down and looping around like this, it would mean it would roll forward here for the fascia underneath. That would be what would be tensioning it. So I would suspect that they're in an anterior rotary position, and they'd be limited coming into depression and retraction. So that would just give you kind of an idea of which one you would expect to be limited. And again, if you can predict this sort of thing, right? If we're predicting it here without actually looking at the person, and that's what you find, it's really good odds at that point that that's part of the pain reproduction problem. Okay. The other possibility that you have to consider is, because you're dealing with some mid-cervical stiffness, even if it's on the opposite side, there's a possibility that you have a mid-cervical segmental facilitation on the ipsilateral side, right? So we talked about this during the class, that in the cervical spine, a lot of times, if I have symptoms on the right side, the restriction that I'm dealing with is on the left side, right? We see that a ton in the cervical spine, especially the mid-cervical spine, because of how the cervical spine should produce these reciprocating movements, with things like side bending, with things like rotation, et cetera. So stiffness on the left, essentially, if we have two joints, whether it's a U joint or a facet joint, these things should move symmetrically in opposite directions with unilateral movements, right? If the left side suddenly becomes stiff, the axis of movement is no longer in between the two joints where we're kind of pivoting around those things. All of a sudden, that axis of movement shifts out to the stiff joint. And so this thing locks up like this, and now we're pivoting around that stiff joint on the opposite side. And so you can see that does a lot more motion here on the right, which could give you a facilitatory effect that will affect some of the scapular musculature. We talked about that clock mechanism around the scapula, where basically every level of the mid-cervical spine, including and even above the mid-cervical spine, including a cranial nerve, where the traps are involved, upper trap and lower trap in particular, surround and innervate most of those muscles around the scapula. So if we have a mid-cervical issue, say it's, you know, a C5 facilitation, you could have issues around the rhomboids that would be affecting lateral rotation, lateral and upward rotation, and abduction of the scapula, and that could affect clavicular position and essentially the appropriate movement patterns around the AC joint. So that could perpetuate some of the problems that they may still be having, whether it's the pain here or, you know, any lingering symptoms of paresthesia, et cetera, into the arm. But those are a couple of things that you could certainly look at. Look at those couple of combined movement positions of the clavicle for SC joint restriction, and then check the mid-cervical spine for facilitatory effects. And I think I mentioned during module 7 when we were in class that I tend to look at the scapular quadrants, right? So in order to determine, do I have a lack of muscular extensibility as one of the best ways to look for mid-cervical facilitation. Because that's going to give me essentially a better feel for, do these muscles lengthen appropriately? Could those things match up with the loss of SC motion that we were talking about previously? It could. You'll have to really rely on your end feel for what's restricting things. Say if we ran into, like we were saying, maybe they can't get into depression and retraction. Depression and retraction would give you hypertonicity of the pec minor, right? So we could have maybe a C7 facilitation that would actually affect that as well. So those are probably the two biggest options that you'd run into there. SC restriction, or maybe something around the scapula that's affecting AC joint and clavicular position and mobility. How's that sound? Good?
Yeah, that's awesome. Thank you. Real quick question though. When you said, what is protraction and elevation? Is that a posterior roll of the
Anterior.
clavicle? Anterior roll? Okay.
To
Sorry.
create an anterior
Thank
roll.
you. Thanks.
Yep. Well, anything else? I don't mind answering questions, because the stuff that I was going to go over today, we can always go over at a later date. So I don't feel like you're taking time away from what I had planned.
I have one, Eric, might be difficult over video chat here, but I'm recognizing more and more abducted ulnas. I have yet to be successful with the manip treatment. Any thoughts, feedback on ways I could troubleshoot? I know it's going to be repetition, but it's getting very frustrating. I've probably seen 3 or 4. I've been unable to correct it. Thoughts?
Yeah, so there's always different options for treating an abducted ulna as far as technique goes. And we went over, 3 different versions. We have what we consider the more osteokinematic technique, which is more this kind of more flimsy whip type of motion that we produce with our one hand on the wrist and one hand on the elbow, and we're just kind of producing the medial glide the lateral glide with that sort of moment. And then we have the more direct, where we get right onto the olecranon, and we're kind of just shooting that thing laterally from there. It's going to be a safer type of technique, but it's going to be less effective. And then we have kind of the middle ground, which is kind of where we usually end up falling, just based off of most people having a very kind of average modulus of elasticity in their body, right? So somebody that's super flexible, if I'm doing that whip technique, I'm probably going to get too much movement out of them, and that just puts them at higher risk for potential complications or injury. Versus somebody that's real stiff. If I'm sitting there trying to do this, very targeted direct lateral glide on the olecranon, may not be able to get enough fixation in order to get the movement that I need. So the kind of the middle ground there is to just get the palm of your hand over the medial portion of the elbow, So basically right there. Fixate the hand underneath your arm, and then you're going to produce more of a, almost similar to some of our cervical techniques. We're going to get kind of into this position and give it one of these sort of things, kind of squeezing those elbows together again, using the shoulder adductors. So you can toy around with different versions of that. The other thing that you could consider here is if it's a fixated lesion, right? So we're talking about a subluxation here. And you're just not getting it right. When we talk about any subluxation in the body, one of the safest mechanisms for actually reducing the subluxation or fixing the subluxation is to do some sort of gapping technique. So you could do some sort of traction mechanism here. Basically, you'd want to put them still in an extended position here. Get your hand on the kind of the front side of the ulna, wrap that finger around onto the olecranon, and then fix the humerus behind it. And you could thrust straight down toward the table, right? So if you actually, you'd almost be holding the arm. You'd want to stand lateral to the arm on the patient, grab that olecranon and ulna like so. So you're almost in kind of a trigger position. Get the arm underneath your armpit, and then fixate the humerus with the opposite hand against the table. And then you could thrust straight down. And what that would do is it would take the olecranon like this, and it would do that. And basically that's just kind of a flat reset. It's very similar to a talocrural manipulation, where we're just trying to gap the joint to get the tissue to just kind of correct itself. So you could try that sort of thing. I do a lot of them where they're non-manipulative, manipulative, I guess would be the word I'm looking for, where I kind of get that same hand position, and I'm just trying to wiggle it loose, right? It's almost like one of those, we call them jerky grade 3 mobilizations, where you're just kind of sitting there wobbling this thing around to try and